is one of the diseases that we must know, because it is might be congenital as well as acquired, So congenital polyps and acquired polyps has got different meanings in disease process. Okay, so there are a lot of polyps. Usually polyps in rectum and colon is different entity nowadays, but for purpose of teaching, we take it as colorectal polyp. But polyps in rectum and colon could be discussed in different groups also. Anyway, so this is what actually the colorectal polyps meant for us in our practical life. Okay, so by definitions, this is a fleshy growth of mucosa. You see, it's a mucosa occurring on the lining of the colon and rectum. So it's a fleshy growth, may be single or part of polyposis syndrome. Why I'm telling this polyposis syndrome is a congenital diseases where you get different varieties of polyps and different presentations. So any mucosal swelling occurring in the lining of the colon and rectum are known as polyps. Okay, so they may be single or they might be multiple as a part of polyposis syndrome. And what is this polyposis syndrome? I'll come now later on. You can see the polyps. You can see how the polyps looks like. You see, they look like polyps. Okay, especially this one is a polyp. Okay, and if you see the pathophysiology, it has got a very genetic preposition, this polyps has got, because they run in a hereditary. So there are a lot of polyposis syndrome, which runs in family, and they have got different syndrome. I'll come later on. So this mutation with certain genes then cause cells to continue to divide even when new cells are not needed. See, that's how the polyposis develops. This overgrowth can cause polyposis. Don't need it in the normal physiology, but they grow. Or it can be developed anywhere in the colon and rectum. Larger the polyps, greater the chances of malignancy. So that's the importance of the polyp. If they are bigger in size, they are multiple in size, then the chances of getting malignancy is very high. So this is what you have to know about polyposis. What are the risk factors? So age 30 years and old. Okay, those in acquired conditions, those are quite older age, you can see the polyps. Or inflammatory intestinal condition like ulcerative colitis, Crohn's. These are one of the pathological process where they develop the cells, where the tissue they develop as a polyps. Okay, the family history. That's what this congenital one, or they run in family. More the family members with the polyps, more is the chances of having polyposis to the individual. So, if the parents, mother and father, the uncle, the maternal uncle, the paternal uncles, if they have got polyposis in the family, so the chances of getting the offspring, the sons or daughter, they might get polyps very much high incidence. Tobacco, smoking, alcohol, obesity, and lack of physical exercises, and very rare in Africans or Americans. Races like them, they have got quite Africans, they have got very less, but Americans races, they have got very high incidence of polyposis. And not controlled diabetes mellitus. In those cases also you can see the overgrowth of the mucosa and the solid polyps. Okay. So there are a lot of different types of polyposis, I told you. Pedunculated or stalk. Pedunculated means there is a stalk, okay? There is stalk and this is polyp. And this one is sessile, with no stalk or no neck. You see, this is the base and this is the neck and this is the polyp. Here you see the polyp, there is no anything stalk. They as if flushed with the mucosa membrane. It's not like that. They are easily to pick up and these are very difficult to pick up. So either this is pedunculated or it's sessile. This one type. And other type might be non-neoplastic or neoplastic. Okay, so this is very important to differentiate which one are what you called oh dear. Sorry. Yeah. Which one are non-neoplastic or benign? Which are...
Sir, slide.
I know.
What's it? I know.
एक मिनट है यहाँ के बिग्रियो कसको अब आयो आएन कि
छैन
होइन कि अहिले आएन कि एक मिनट है जस्ट अ मिनट के चलाएर पनि ठ्याक्कै ठुलो गराएको त हो आम्मा कसरी गर्ने त्यसलाई चाहिँ के गर्ने ल जस्ट अ मिनट है गिभ मी 1 मिनट वो गइरहेछ यसरी के गर्नुपर्छ के छ स्लाइडिङ हुने लाग्छ त्यो यताउता गर्ने त्यही कारण त्यो उयो आएको छैन कि हेलो
छैन सर आएको
मैले ठ्याक्कै त्यो ठुलो गरेर स्क्रिन गरौँ होइन त्यो हाल्नु त एकचोटि क्वेसन सो प्रेजेन्टर भ्यू रे यो सो प्रेजेन्टर भ्यू गरौँ एकचोटि स्क्रिन स्क्रिन एरो अप्सन डिस्प्ले सेटिङ एक सेकेन्ड है भाइ आएन कि एक मिनट कहाँ बिग्रियो त यहाँ हाम्रो को आएको थियो एक सेकेन्ड है अझै आएको छैन है पैथोलोजी क्लास शेयर आयो
छैन सर
तेरीका कहाँबाट आउँछ यो यहाँ कोही पनि नभएर बिग्रियो केटाहरू पनि छैन अहिले आएन कि शेयर भन्नु आउँछ तर यहाँ जाँदैन भएन बनाउनु पर्यो त्यसलाई
सर महेश दाइ हुनुहुन्न त्यता
महेश लन्चमा गएको छु क्या त्यो महेश भएको भए उठ्यो सहिलो हुन्थ्यो मलाई फेरि यो लामो क्लास छ अलिकता एनिवे ओके म आई जस्ट गो न्यारेटिङ अनि पछि स्लाइड देखाउँछु है त मैले है हेलो ओके मैले अघि भन्दै थिएँ नि अकर्डिङ टु हिस्टोलोजी देयर कुड बी नन नियोप्लास्टिक एज वेल एज नियोप्लास्टिक ओके नन नियोप्लास्टिक भनेको चाहिँ दे आर नट बेनाइन एट अल बट दे आर पोटेन्सियली दे कुड बी व्हाट यु कॉल्ड malignant also okay so either they could be hyperplastic one or they could be hematomas or inflammatory non-neoplastic okay so they are always arise from the epithelial cells so the benign component of these non-neoplastic are neoplasma inflammatory and hematomas or metaplastic so might be new cells or inflammatory or very combined of different cells or metaplasic, means there is change in the cellular configurations. So these benign non-neoplastic cells might turn into malignant and become adenocarcinoma. Okay, I'll show the slide later on. And the neoplastic one is either adenomas or serrated type. So they are always from mesenchymal origin. So either they could be fatty lipose tissue or fibrous tissue or leiomyoma from the muscles or hemangioma from the vessels. So these are usually the malignant component are the sarcomas or lymphomas. So according to histology also, non-neoplastic and neoplastic. Non-neoplastic, they are epithelial origins. They change to neoplasma or inflammatory hematomas metastatic. They might, the malignant component adenocarcinoma, whereas neoplastic one, they are adenomas or serrated type. They are origin from the mesenchymal. So mesenchymal tissue.
Excuse me, sir.
Hazard?
So एकचोटि डिस्कनेक्ट गरेर फेरि कनेक्ट हुनु न अनि आउँछ कि
यहाँ डिस्कनेक्ट गरेर पनि आने चलाइदिने मान्छे नै भएन के म डिस्कनेक्ट गर्छु कि त आई जस्ट ट्राई टु डिस्कनेक्ट इट फेरि आयो भने लेट अस सी ओके आयो आएन कि खै त यहाँ चाहिँ किन हान्यो ए ल ट्राई गर्छु यहाँ चाहिँ सिक्नुपर्ने भयो हामीले पनि यार जहिले पनि अरूले गरिदिने भएको होइन तिम्रो त चलाक छौ तिम्रो सबैले हजुर
उसने नंबर लिखवा दिया मुझसे
देख यहाँ पे अबे आवाज आ रही सुन ना सृजनशील नंबर पता है ना कहाँ
को कुरा गर्दैछ यार आएन है कहाँ छ यसको क्लिक टाइप म चाहिँ बोलाउनै पर्यो तँलाई 80% युसेज फुल स्लाइड रिडिङ भ्यू स्लाइड स्टार्टर नर्मल कमेन्ट नोट्स
हजुर आफै कलबाट लिभ गरेर एकचोटि फेरि जोइन गरे भने हुन्छ होला
म ट्राई गर्छु है त
हस् सर
इजराहरू Welcome to the class. I want to get activities, chat, heal. तिम्रो मात्र आइरहेछ यार होइन यो आउँदै होइन उनीहरूको आइरहेछ बिचराहरूको फोटो यो उ त क्लासमा मैले चाहिँ उ गरेको छु मैले होइन सर्जरी क्लास भने त आयो कल को आउँदैछ महेश शरद शरद ए महेशै आएछ
टिम्सबाट पो गर्ने हो
मेरो क्लासमै गर्नु पर्यो
सर्जरी क्लास यो भइरहेको छ कन्टिन्यू भइरहेको छ
मैले त्यो आएन स्लाइड आएन कि
स्लाइड आएन भन्नु भयो त स्टार्ट सेयरिङ गरौँ है
यो होइन यो त आइरहेछ क्लास मात्रै रहेन
क्लासको लागि सेयर कन्टेन्ट विन्डो
त्यो स्लाइड चेन्ज गर्दा उता देखेन
सरको स्लाइड ओपन छ अहिले
ओपन छ
छैन सर
छैन क्लोज मैले क्लोज गरेको थिएँ
क्लोज गर्नुभएको छ सायद कहाँ छ सर स्लाइड
त्यसमा छोडा
डेस्कटपमा छ
डेस्कटप मैले चाहिँ उठाएको थिएँ
डेस्कटपमा सर
यसमा छ यो हो हो यहाँ चाहिँ को स्प्रिङ नट अनलाइन यो मेरो होइन कसको हो यो होइन मेरो
यो होइन सर
त्यसबाट ल्याउनु फेरि
ए यसमै छ किङ म्याक्स
हो भनौँ भन्ने छ होला सिस्टम भन्ने होला सिस्टममा जाउँ यसो इङ्ग्लिस क्लास जाउँ त यसमा चाहिँ कोलोरेक्टली सी यो
छ ए यहीँबाट स्टार्ट गरिदिउँ
हुन्छ यो चाहिँ डाउनलोड गरेर पनि हुन्छ
हेलो हजुर सर छुट्टीमा होइन सर म हजुर 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 यता एडिटोरियल पोलिसी ए हुन्छ हस् 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 ए हस् हुन्छ हस् हस् यो भएर अब आउँछ सर उतापट्टि देखिरहेको हुन्छ सर एकचोटि होइन हजुरहरूले देखिराख्नु भएको छ स्लाइड स्क्रिन सेयर भइरहेछ
हजुर अब भयो दाइ
स्क्रिन सेयर भयो है अब प्रेजेन्टेसन पनि देख्नु भएको छ है
यो स्लाइड सो नगर्दिनु दाइ यतिकै
हुन्छ म गरिदिन्छु ए अब देखिन्छ देखियो नि है
हजुर
कपी गरिदिनु भन्नुभएको छ कपी गरिदिन्छु यो हो सर है हजुर डेस्कटपमा कपी गरिदिन्छु सर डेस्कटपमा कपी भएको छ सर हजुर आइराखेको छ है अब देख्नु भयो नि है हजुरहरूले ओके हस्
यो निकालौँ
निकाल्दा नि हुन्छ चल्छ
ओके सरी है ठिक छ आउँछ अब ओके मैले यो कुरा गर्दै थिएँ त्यो बेला कि यो नन नियोप्लास्टिकको बारेमा सो नन नियोप्लास्टिक इपिथेलियल ओरिजिन हो जब नियोप्लास्टिक मेजेन्काइमल सो यु क्यान सी बेनाइन कन्डिसन र नियोप्लाज्मा और इन्फ्लेमेटरी कन्डिसन हिमाटोमा भनेको बेनाइन बट डिफ्रेन्ट सेल्स अफ ओरिजिन मेटाप्लास्टिक भनेको चाहिँ द सेल चेन्जेस इट्स सेप बट दे आर स्टिल बेनाइन तर जब त्यसको कम्पोनेन्ट चिज काउन्टर कम्पोनेन्ट इज एडेनोकार्सिनोमा जब नियोप्लास्टिक भयो भने दे आर अलरेडी एडेनोमा बट दे आर अलरेडी प्रिडोमिनेन्टली मेलिग्नेन्ट ओरिजिन अनि सिरेटेड टाइप भन्ने हुन्छ दे आर मेजेन्काइमल ओरिजिन so lipose fibrous tissue leiomyoma muscles origin the hemangio blood vessels so they change into sarcoma or lymphoma okay other classifications that color polyp is either inflammatory that is pseudopolyps or ulcerative colitis usually they are not typical polyp because they don't have all the layer of the cells of origin tissue of origin just they are polyps like but they are pseudopolyps. Metaplastic means these cells, they hyperplastic, they are overgrowth, so they are metaplastic, they change their nature, so those type of polyps are known as metaplastic polyps. Hematoma, so these are different cells of origin in one polyp, like in Purjagus polyps, juvenile polyp, they are hematomas, they have got the origin of different cells. And neoplastic, they could be either adenoma, their type is tubular or tubervillous or villous. Villous maneko cauliflower-like growth of villous mancha. And either they could be adenocarcinoma or carcinoid tumor. I'll come to that point. So these are the things you can see in classification of polyps. So the pathology of polyp is Why these inflammatory polyps they occurs? Because there is inflammations like inflammatory bowel disease, like ulcerative colitis or Crohn's disease. There you can see the polyps comes out. There is overgrowth of the tissue. Okay, either they might be pseudo polyp, don't have all the layer of the polyp of a typical polyp, or there might be all the type of there might be also true polyps in inflammatory polyps. Or hyperplastic means found in distal colon and rectum, have no malignant potentials, but they have got overgrowth. They have got they grow very fast. Hyperplastic. So either the right-sided polyp exhibit some malignant potentials, and serrated means there are a lot of serrations in the polyp, like in what you can see in the wart, something like that. They are known as serrated polyps. And three histological pattern of growth is microvascular or mucin pore or goblet. So these are the histological pattern of polyps, okay? And pathology, this is very important, is that familial polyposis, edematous polyposis, a form of heterotrophic syndrome, okay, in APG genes, genetical factor, develop in multiple polyps early age, hundreds of even thousands. You can see this here. These are all small polyps. This is a colonoscopy picture. These are all, you see, the thousands of polyps you can see in the colonoscopy. Okay, if left untreated, okay, then they might change in malignant potentially. So 100%, if you don't treat properly, they will change in carcinomas changes, okay? And the autosomal dominant, because they are hereditary, 10 to 10% have negative family history only, and remove all of the affected tissue before 40 years, So if somebody has got this type of polyposis, family edematous polyposis, with the genetic predisposition, then you have to remove whole of that intestine or the colon or rectum where there is a lot of polyposis or multiple polyposis, okay? Because they have got almost 100% chance of getting malignant. And Gardner syndrome, this is a familial edematous polyposis variant. Polyps in colon and small intestine throw out, okay? And they have got other lesions also in skin or bones or abdomen. You see, there are multiple swelling in the scalp, and there is a patchy things, and you can see the alighting area in the dental area or in the gums. So these are the syndromes. So when somebody comes with multiple swelling in the forehead or in the body, and with the pain in the maxilla or mandibles, and if you take external lytic area, always think of Gardner syndrome. You must examine for the rectum or the rectum and colon to see any polyps are not there. So this is known as Gardner syndrome. And the associated polyp MIS is a familial edematous polyposis due to mutation of MIS gene, the genetic one. So multiple edematous polyposis can cause cancer colon in young age, and genetic testing is advised. So that's why it is very important to see in the familial history whether the parents has got any polyposis or not. Lynch syndrome, the hereditary non-polyposis colorectal carcinoma, hereditary non-polyposis colorectal cancer, and SSCC, hereditary colorectal carcinoma syndrome. Lynch syndrome is that autosomal dominant, early onset, mean age 44 years, few colonic polyposis but turn malignant early, mostly proximal colon. Growth mucinous polyposis differentiates adenocarcinoma, synchronous or metachronous cancer cells. Synchronous means there might be polyposis at the proximal end, and at the same time there might be polyposis in the distal end, okay? Or there might be polyposis in the colon, and there might be polyposis anywhere in the upper GI tract also. So that's known as metachronous cancer or synchronous. They might be at the same time, or they might be present later on also. So good surgical resection has better outcome. It includes cancer of endometrium, breast, ovaries, gastric, small intestine, pancreas, ureter, and renal pelvis. So if you see any malignancy in these areas, and along with the polyposis, they are known as metachronous cancer So they might be at the same time they might present, or they might be time come after 6 months, 6 months of that. Okay, so these are the Lynch syndrome. And Peutz-Jeghers syndrome, as I told you in before, I don't want to repeat all these things. You can see that a lot of mucosal or oral pathology, patchy. You can see the what you call flakes of like the hemorrhagic in the lips or gums or in the palate. And along with that, there are multiple polyphosis in the colon is a Peutz-Jeghers syndrome. Okay, once you see any what you call pigmentations over the lips or in the palate or in the tongue, then always think of Peutz-Jeghers syndrome when you ask the patient if he has got any feature of polyposis. Juvenile polyphosis syndrome, the hematomatous polyposis, risks of cancer intestine or extraintestinal, present with bleedings and obstruction of intestine tract with low serum developing malignancy, and surgical removal and close follow-up is very important. So this juvenile polyposis is again genetic predisposition. Neoplastic polyps, lots its normal tissue, lost its normal tissue differences. Means neoplastic, they change the histology of the cell. They may be benign or malignant growth, primary or secondary. Becomes malignant once it invades muscularis mucosa. And then it involves lymph node. Distant metastasis can occur with increased chance of local recurrence needing extensive resection. So once you see any polyp, you go for colonoscopy, you take the biopsy and see all these features are there or not. If there is malignancy, then you have to remove, you have to go whole length of colon if there are polyps in the proximal end. So neoplastic polyps, they are already changed into malignancy. I have already told I'm not going to discuss all detail in this neoplastic polyps, adenomas, or I'm not going to talk all these things because you don't need much. So risk of cancer in relation to the size of polyps. If there are less than 1 centimeter, the chances of cancer is less than 1%. If 1 to 2 centimeter, there is chances of 10% risk of cancer. And if it's more than 2 centimeters, it's 50% risk of cancer. So if you see the polyp, single or multiple, and they prove out to be histological malignant, you can you can just see the size, and they can be correlated with the malignancy potentiality. So that's very important. And number of polyps that present, that also depends on, and that tell you the malignant potentiality. So any polyps is more than 2 centimeters, the chance of getting cancer is almost 50%. That's why you have to see. So the size of malignancy is the magnitude of malignancy that depends on the size of the polyp. So if you see more than 1 centimeter and 2 centimeters or more, they have got more potential of getting cancer, malignant change in the polyp. Polyps cancer based on the depth of the invasions. I think it's not much important for you, but if you see, the more it go invade the deeper tissue, okay, muscularis mucosa or invade submucosal regions, then involve the neck of the polyp, then invades the submucosa which involve in the part of the stalk, invades submucosa below the stalk, but above the muscularis propria, then the level Haggett's criteria is that depend upon the depth of the involvement of the muscularis mucosa. They have divided in very fine cellular differentiation of invades, the level 0, 1, 2, 3, 4. I think just remember that there is one classification like this. And I'm not going to talk about all this part. Actually, this is very important to understand. Once in the beginning of the development of the polyps, just there is invasion of the submucosa, but limited to the head of the polyp only. As you can see, the mucosa involvement only head of the polyps. This one, you see. There's a polyp there, the mucosa is there, and only the mucosal layer is involved. Okay. Then this is the body of the polyp, and this is the neck of the polyp, okay? And once this level invasion extends to the neck of the polyp, this is level 2. And once it goes to the stalk, okay, down there, the level 3. And level 4, then this is the muscularis propria. So once you involve the muscular propria, it's level 4. So only involving mucosa, you can just take it out from the stalk, or even in the invasion of neck, you can take it out. But once it goes invasion, the neck of the polyp, then it has invaded the muscularis propria at level 4. It has already started metastasizing through the lymphatics. So these are the polyps, this level 1, 2, 3, 4, that you just remember this picture, then you will be able to describe the level of the polyp to change in the malignant potential. The prognostic factor, the polyps transfer to carcinoma. The prognostic factor, polyps are less than 1 centimeter, usually more than 1 centimeter, usually carcinomatous. So less than 1 centimeter is not carcinomatous, as seen in the size wise. So polyp size less than 4 millimeter, usually hyperplastic. Okay. Sessile polyps more than 2 centimeter, usually villus type with high malignant and recurrent potential. So these are the one no stalk, but they are sessile. They invades the tissue very fast than the pedunculate one. Peduncular needs to travel long distance to invade the soft mucosa, whereas sessile one can just invade the basement membrane. That's why they have got more potential, and they spread very fast. So if you remember sessile polyps, the potential of recurrence is very high. That's why you have to see if the polyp size is more than 1 centimeter, they are more carcinomatous. If they are more than less than 4 millimeter, usually hyperplastic one. Sessile more than 2 centimeter, they are more dangerous than the peduncular one if they are more than 2 centimeter. The sessile one is having more potentially, having more malignant potential. The prognostic factor, if you see a high power, histologically, high power examinations, villus type has got highest malignant potential as it has greater surface area. So 2 centimeter size tubular adenoma has got 35% risk of cancer. 2 centimeter size villus adenoma has got 50%, villus type has got what you call 50% cancer. Multiple polyps, FAP, familial adenomatous polyps, has got 100% risk of cancer. So this is very important. You have to find whether the polyps has got familial relation or not. If the father has got familial polyps, and the son has got polyps, then they have got a familiar relation. So in those cases, the chances of malignancy is 100%. So I'm not going to a fixed one. So age 60 years, family history, smoking has the peak incidence of cancer. Okay, that's what age-wise, over the age of 60, family poverty, family history, and smoking history has got incidence of cancer. Okay. And clinical feature-wise, age more than 50 years, male has got more prevalence and positive family history, rectal bleeding, change in the color of stool, red streak or black. Usually these are with red streak, fresh blood, but when they stay for a long time inside the rectum, they become black. That doesn't mean that it's melena. Okay, there is bleeding still for a long time in the rectum, that's why they become black. Change in bowel habit, constipation or diarrhea lasts for longer. Okay, then a week or presence in the polyp in the colon. If you get the polyps, there is change in the bowel habit, you always think of carcinoma. Increased mucus productions. There is a bleeding with mucosa, the slippery sort of stool with blood mix. Pain and fatigue and future intestinal obstruction. Sometimes there is a lot of bleeding, they have got anemic and they get fatigue and fissure of obstruction because there is tubular growth or the polyps are so big enough, they obstruct the lumen of the intestine and they present with the intestinal obstruction. And iron deficiency anemia because they lose a lot of blood. That's why they become anemic. And hypokalemic and hypoalbuminemia, okay? They have got a lot of, the potassium is lost too much and the albumin is lost too much. And always you do digital rectal examination and you see the finding. So if you see these people, a person with, a male with more than 50 years with family history of polyps and rectal bleeding, change in bowel habit, and they have got a feature of anemia, like in iron deficiency. Then they have got hypoalbuminemia, the swelling of the leg or face, and urinary problem. If you do a DRE and you find the polyps, always think of a colorectal polyps. Investigations for the diagnosis, the most important is DRE. Don't forget to do any patient having bleeding to try to pass your finger, index finger in the rectum, anal and rectum, and see if you can feel it, some swelling or some growth or some sort of abnormal features. Okay. If not, then do a proctoscopy. You can do a sigmoidoscopy, colonoscopy, or sometimes you can do virtual colonoscopy or capsule endoscopy. Okay. Then in previous day, we used to do barium enema. It's not indicated nowadays. Always go for occult blood in the stool and do CBC, and ESR is high. You have to go for CT or MRI or angiogram and other baseline investigation like CBC or blood sugar and chest and all these things. So this is the diagnostic investigations. And treatment is polypectomy. If there are single polyps, benign, look, cut the stalk at the cutter. You see, in this is a pedunculated polyp, and this is a snare. You pass it and rotate it and cut it and take it out. You see, these are steps of taking out what you call the polyps. Okay, you see, they have put the local injections and they have put the snare and they have cut it. Okay, and it's like this. So this is how you take endoscopic resections of the polyp. And polypectomy, limited colectomy, if you see the polyps are extensive, so you can remove the just colon, okay? This all colon you can remove any extent depending upon the where it is. They have removed whole proctocolectomy. They have removed whole and left the rectum, and they joined this ileum and rectum, okay? So this is what is proctocolectomy, and this is known as the ileoanastomosis. In those cases where there are extensive polyposis, then you remove colectomy. Whole colon is removed up to the rectum. That might be one of the treatment of pancolectomy, okay? Prevention, change in the diet and lifestyle. Always take high fiber diet, reduce the fat intake, limit alcohol and especially the tobacco. You have to quit the tobacco. Or you can stay even with the person who is having tobacco itself. Maintain body weight and physical exercise. That's very, very important. What one can do very easily. Then have calcium or vitamin D, and that prevents a lot of disease of carcinoma. That's very important. And regular colonoscopic checkup for high risk patients every 6 months. In Western countries, especially in the Europe, they go for colonoscopic checkup every 6 months because the incidence of colonic carcinoma due to polyps is very high in those areas. Okay, that's why they have to do. So if you just change your bowel habit or by having high fiber diet or reduce fat intake, don't smoke at all, unlimited alcohol. You have to do a lot of physical exercise and use calcium and vitamin D that prevents adenocarcinoma, okay? So this is what exactly polyps means, okay? So I think the most important part is this. You have to remember anybody has got history of polyps or rectal bleeding and change in bowel habit, and there is anemic features. And I'm not going to this, but remember that any polyp is more than 2 centimeters, they have got high risk of carcinoma. Whether they're any type, whether tubular type or villus type or multiple polyps, they have got very much high incidence of what you call this. So always think of age 60 years, family history. Smoking is very important indicator for polyps. And as I told you, prognosis to fracture. Then this is very important. You have to understand level 1, 2, 3, 4. And again, I repeat it. This is the mucous membrane, and this is what the polyp that from the mucous membrane. This is a lamina propria, and this is limited up to the head of the polyp, and this is only towards the what you call the neck, and is already crossed the neck and stalk, and it is all subcutaneous layer, so submucous layer. So That's the level 4. So once it reaches the submucosal propria, then there are a lot of lymphatics, they start metastasizing before they come to the muscularis or serosal layer. That's very important. Level 4 is very dangerous. So you can't even snare it. Okay? Level 2, that's okay. But level 3 and level 4, you can't snare it. You have to remove whole of the polyps. So you have to do a extensive surgery. I'm not going to talk Haggett's test criteria. Risks of cancer is less than 1 centimeter. As I told you, if you see between 1 and 2 centimeter, all of think of the incidence high carcinoma of the polyps. And actually, the adenomas, neoplasma is one type of the epithelial origin are tubular or tubulovillous or villous. Villous means like a you see in the multiple fingers like coming out, So they are more malignant potential. And always think of stalk one has got a late potentially, and they have got less chance to get metastasis rather than the sessile one. Sessile one is always, they spread down below to structure very fast than the pedunculate one, okay? Sorry. I'm not going to talk much about this. So as a Purge syndrome, as I told you, if you see any coloration in the lip or in the palate or in the gum, always think of Purge syndrome and always look for the polyposis coli. Lynch syndrome, I think I'm not much interested. Amyloid polyps, these are all genetically related polyps. Gardner syndrome, a patient having polyps or develop any changes in the skin, bone, or abdomen. Okay, always think of this thing, especially in the mandible. They have lytic areas. They might have a lot of lytic in other bones also. Okay, this is a familial adenomatous polyposis. This is one of the variant. As I told you, all this you can see like this, flooded with polyps. So the classification, if you remember, inflammatory, metaplastic, hematomas, and neoplastic. And neoplastic adenomas is tubular, tubulovillous, and villous. And adenocarcinoma, and carcinoid tumor, you can see most in the appendix and cecum region. So ulcerative colitis and Crohn's disease, you can see a lot of polyps which are pseudopolyps. They don't have all the layer of the polyps as such, okay? So this is what I have told you. So these are the types of and shape of polyps. So this is a simple thing. Then the message you have to carry home is any polyp, don't take as a benign. That's the message. Any polyp, rectal polyps or colonic polyps, you don't take it as a simple polyp. You have to prove it that it's simple, it's not a malignant one. Then only you can proceed and give a clean sheet to the patient. Okay? That's how the polyps are this thing. And mostly the colorectal carcinoma, you can see in the Western countries, they say that they develop from the polyp first. Before if you miss it, the polyps in your early years, they might change into the malignancy. Okay then. Yeah. Hello?
Thank you, sir.
Hello?
Also,
Hello?
sir.
Thank you.
Thank you, sir.